Thank you for joining us. I'm Dan Cass. I'm a Senior Vice President here overseeing the Environmental Health Program, and I just want to welcome all of you and thank you for joining us so early in the morning. Judging from the milling about as we prepared for this morning, I think mostly we want you to thank us for giving all of you an opportunity for what looks like a giant reunion of friends. So thank you for joining us. Tonight, or this afternoon, it's really early and the coffee hasn't kicked in. This morning we're going to talk about the U.S. opioid crisis, and we have some esteemed guests. But let me tell you just a few words about Vital Strategies for those of you who don't know much about our organization. We're about a 400-strong person global public health organization. We have programs in 73 countries, and most of the work that we do involves strengthening public health systems, in particular working with governments and civil society to really strengthen the tools that are employed for advancing public health agendas. We do work both that's content specific, like this program that's sponsoring today's convening around the drug epidemic and the overdose epidemic in the United States, tobacco, environmental health, but we also do programs that are oriented generally towards strengthening public health. We have a Data for Health program, data to policy. We work on epidemic preparedness. And so we're really pleased to have you join us this morning at Vital Strategies, learn about the work that's going on here around the overdose crisis, and hear from a couple of really wonderful guests today. We're joined today by Daliah Heller, who will be moderating the panel. Daliah has over 20 years of experience working on this issue. I met Daliah probably a little over 10 years ago when we were both at the New York City Public Health Department, and we're so pleased to have her here at Vital Strategies to join us on this. She has a range of experience both in and outside of government and brings enormous insight into how to address this problem. She'll be moderating a panel with Tracie Gardner and Dr. Chinazo Cunningham, whom she'll introduce, and so I want to turn it over to Daliah. Thanks.
Thank you, Dan, and good morning, everyone. Thank you for being here early, as Dan noted. So I hope the food's made up for it. We appreciate you showing up today and being part of this discussion with us. So as you know, I know many of you in this room and many people in this room have been working on this issue for many years longer than me. But I'd just like to ask a simple question, because I ask this sometimes when I'm asked to guest teach. Often friends ask me to guest teach a class on drugs. And so I've started asking, how many people in this room know somebody who we've lost to overdose? Raise your hand. Yeah, so that's what happens when I teach a class too. And it's so striking, and it's not new, but it's gotten so much bigger. And so I'm really honored to have the privilege to lead this initiative here at Vital Strategies. It's an extraordinary privilege, really, to be able to. I'm leading the overdose prevention program here, and our role is really to work in states in this country to bring a comprehensive approach to reducing overdose deaths in states. So that means we're coming in, we have funding from Bloomberg Philanthropies, and we're able to work with everybody and to identify opportunities where we can really see a sustainable reduction in overdose over the long term. We're working across sectors with criminal justice sector, in the healthcare sector, social service sector, public health. We're working across levels of government, so with state governments and city and county governments. We're working with communities, grassroots coalitions, large institutional providers, healthcare networks, professional associations. So we're not limited in any way, and we have this extraordinary opportunity to actually do something and demonstrate that we can change this problem. I'm going to talk a little bit about our approach, but then really my conversation with Tracie and Chinazo, I hope will really kind of help us unpack a lot of how we got here and what we can do to reverse the overdose epidemic in this country. So we're bringing an approach, this comprehensive approach or kind of landscape view to Pennsylvania, which led the country in overdose deaths in 2017, the last year we have data for, and to Michigan, which was in the top 20 as well. And numbers have been rising, as they have been in many states. But as I said, we're not just focused in one small area. We're trying to really bring a landscape view because we recognize that drug use touches all areas. Drug use is involved in the criminal justice system. Our Director of Communications, Tony Newman, reminded me this morning that today is the 46th anniversary of the signing of the Rockefeller drug laws in New York, which was the beginning of really how we've gotten to where we are today, which is, leading the world in incarceration of our population. But we also know that people can't get treatment if they want it. So where do they end up? They end up in jail and prison. We know that if we keep punishing people, we're not changing anything about what's happening with this, what we recognize now, and I think is sort of widely understood to be a health issue. So we're working in the criminal justice sector to actually try to reduce incarceration. So for example, we'd love to see probation stop using drug use as a reason to call a technical violation and send somebody to jail. We know that if somebody under probation is using drugs, that it would be, the best approach would be a probation officer offering them services, connecting them to support and help. But we know that those technical violations are filling our jails. We'd like to see opioid agonist treatment available in emergency departments so that when somebody can walk into an emergency department, somebody can end up in an emergency department on a drug-related call, for example, after a non-fatal overdose, they've been revived, they come to the emergency room, they're brought to the emergency room, or they come in on some non-drug-related health problem. And there should be an opportunity there to be able to offer that individual Suboxone or buprenorphine, an engagement in a treatment that we know is actually protective from overdose. So if somebody is using an opioid agonist treatment, their tolerance is maintained. So even if they go off that treatment, go back to drug use, the likelihood is less that they would actually, it reduces their risk for overdose, reduces their vulnerability. So these are the kinds of things we're working on, but we really want to see, what I call this is a harm reduction approach. And we've used that word a lot, and it's largely associated with, very specifically with tools such as syringe exchange or naloxone more recently. We'd like to see naloxone available everywhere, just like the Surgeon General. And fentanyl test strips now, we also consider sort of a harm reduction approach so that people can find out what's in the drug they're using. But thinking broadly, what is a harm reduction approach? I think it's what we would say is no wrong door, so that wherever somebody ends up who's using drugs, there's a helping hand, there's support offered, there's engagement, rather than what we know happens, which is, baked into a lot of our systems, is stigma, moralization, and criminalization. So our work is really to try to reshape this landscape, working with our partners in the two states, and hopefully being able to model what we'd like to see happen elsewhere in this country. So it's my great pleasure today to have a conversation with Dr. Chinazo Cunningham and Tracie Gardner, two amazing women who I've had the pleasure of knowing for more than 20 years. And working with over those years. So I'm going to welcome them to the stage. And you have their bios, but I have to add little personal, kind of something I remember about these two people. So let me say, Dr. Chinazo Cunningham used to work with an organization I used to run in the Bronx, providing harm reduction services. And Dr. Cunningham was the medical provider. We went and did outreach in single-room occupancy hotels, and in the evenings, into the nighttime. And I have this very vivid memory of Chinazo had her third child, and she had to leave us when we were doing door-to-door knocking through this SRO hotel because she had to pump in the van outside on the Grand Concourse. And I mean, I'm just saying that because I'm saying, talk about women who have been juggling many things, child rearing while they were leading and providing an example to this country of what we can do to address drug use. So that's my great memory. Chinazo told me I could tell that story. I just have such a great memory of, where's Chinazo? Oh, she's in the van, she's pumping. So it was, yeah, amazing. And it is now, a nationally renowned researcher and a remarkable clinician still doing great work in the South Bronx. So please come to the stage. Tracie Gardner. Tracie Gardner has been an extraordinary advocate. I think everybody in this city knows her. I think most people in this state know her. If you've worked around HIV, harm reduction, drug use, drug treatment, and communities of color in this city, in this state, and frankly in this country, you know Tracie Gardner. So I've had the pleasure of being probably on the steps of City Hall with Tracie, in the halls of Albany, God knows how many times, but she's been there way more times than me. And so we're really grateful to have Tracie as part of this panel. Please come to the stage. Is it comfortable?
Mm-hmm.
Great. So I've talked a little bit about the approach that we're taking at Vital Strategies to address the overdose epidemic, but how did we get here? Tracie, what would you say? How did we become the world's leading incarcerator? How did we end up in a place where we have fentanyl contaminating the drug supply and contributing to this real spike in overdose deaths that we've seen, where people can't get treatment even when they want it? Where did this come from?
So many people know this is not our first opioid epidemic. And previous responses to health crises, I think, are instructive here. But mainly, we're here because of othering. We're here because of stigma, and fundamentally, we're here because of racism rooted in the institutions, anti-Black, primarily as an outgrowth of slavery. And if you keep in mind that slavery was, relatively speaking, about 15 minutes ago, then it makes sense in terms of where we are now. What I found striking is this struggle to find treatment, particularly in communities that had, quote unquote, not really experienced addiction. And it's kind of the legacy of NIMBYism, the legacy of this won't happen here, our kids are good, those kids are bad. So we have no methadone programs where they are really needed. We have not enough doctors who can prescribe, not just prescribe the FDA-approved medications, but who actually understand addiction, right? Mm-hmm. Like, we are operating in 17th, 18th, maybe 19th century addiction care when we need a 21st century care approach. Mm-hmm. And so this is, we're reaping what we've sown, which is the kind of relegating these issues of the brain to the criminal justice system, to institutions, and allowing healthcare to renounce its responsibility to treat mind and body. I mean, it's really, in some ways, if you can look about how we got here with this kind of mortality, it has to go. You have to go into the history, and I find that people don't really want to do that, but we will do this again. If we don't understand the history, there will be another epidemic, and if we do what we did before, we'll be in worse condition.
Mm-hmm. Thank you. Yeah. And Chinazo, how do you see that play out? As a physician working in the South Bronx, how do your patients experience these issues, and how does drug use affect their lives? What are their opportunities?
Right. So, I mean, as you mentioned, this is not new. This is not new in the Bronx at all. This is something that has been around for decades, and nobody really cared. Honestly, nobody cared until the demographics changed over time, and so. As more of a white population, as more of a suburban and affluent population became affected, then we saw a shift in the paradigm. So, before we were incarcerating people. I mean, we still are, but that's really what the solution was, 20 years ago. And then when we saw the shift in the demographics, all of a sudden we're talking about addiction being a disease, being a brain disease, needing a health, based approach. Which is great, because we do need a health-based approach, but it's sort of, why are we talking about that now? How did we get to this point? Really is about the shifts in the demographics, and many of my patients feel that, absolutely. So, before, it was people were getting arrested all the time, even arrested for having the medications that I was prescribing them, which is unbelievable. And this is a story that I've heard over and over, that if my patients had their medication, which is a controlled substance, buprenorphine, on them, and they would get picked up because of where they are and who they are and what they look like, and end up arrested for getting treatment, for coming to the doctor and getting treatment. Right. And to hear that story over and over is so demoralizing and deflating. And these are people who are looking for help and struggling with their addiction. And so that's the sort of interplay that we would see in terms of the criminal justice system and in terms of really being a health-related problem. But it is a struggle. And what I would say is there have been all these disparities in healthcare that we know. And one of the biggest disparities has been around pain and around opioids. So 15 years ago, and there are many studies that demonstrate this, that people of color were less likely to have their pain seen as real, and therefore less likely to be prescribed opioids. Right. Pharmacies were also less likely to dispense opioids as well. So this disparity actually became protective in some ways, right? Mm-hmm. Because so much of the opioid epidemic has been around the pills, the opioid analgesics for pain. So we have had addiction in our communities in the Bronx, and therefore we've had methadone programs. And so while there became this shift in other communities, these other communities are now so ill-prepared to deal with addiction, whereas at least in the Bronx, we have been prepared because nobody wanted those methadone clinics anywhere else. Right. And so they're in the Bronx. Yep. And now we're in the middle of this epidemic, and now we're actually well-suited to be able to address the epidemic. Right. So it's this irony, actually, about the fact that nobody wanted this to deal with addiction or to say that it involved in their communities. So the methadone programs ended up in communities of color, and the doctors who were doing addiction did it in the communities of color, and now we're the ones that are prepared because we've been doing this for decades.
Yeah, absolutely. Right. And I would say that it's easy to talk about New York, especially when we talk about Rockefeller drug laws being the mother of, mandatory minimums and kind of this idea of putting people who, for the most part, nonviolent drug offenders were people with health issues that we were throwing away for decades. And so my organization, Legal Action Center, actually got started to address the fact that Rockefeller was resulting in putting people with this health issue into the correctional system. I think that anywhere in this country, and certainly if there is stupid drug policy with coupled with enforcement around that drug policy, you will see health inequities in communities of color everywhere in this country. You will see that health and mental hygiene do not live together, and that they're relegated to separate systems, separate funding, separate providers. And so, this is not unique to New York. It is baked in statutorily everywhere around this country, this notion of other, this notion of black and brown people. And one other thing I would point out as we start talking about like why is criminalization in this discussion? Even there's no rationale for even how we have categorized drugs, right? But both Nelson Rockefeller and Richard Nixon initially embraced treatment and humane response to heroin. It was happening among Vietnam vets, and in New York, it was, our first heroin epidemic, and there were actually really smart and compassionate and clinically based approaches. But then when you run for president and you've got to do tough on crime, war on drugs, they literally shifted from we're going to take care to we are going to punish. And of course, the perception of who was affected, that also shifted with from compassionate to war on drugs warrior.
So would you say then, I mean, just to say it, would you say we need to decriminalize drug use?
Oh, we need to do a bunch of things, including
What does that
decriminalize
look
drug
like?
use. But I mean, that's part of it, right? Because there's an economy now that's associated with illicit drugs. And of course, decriminalizing is happening around the world, and we're in many ways on the verge of legalizing marijuana, for example, which has been hand in hand with the criminal justice system. But we need to adopt a culture of prevention. We need to better understand and want to understand why people use drugs. And I don't know where the word entitlement got a filthy name, but we need to have people feel entitled to health. And so if that is where we start building, if we can reproduce like 1,000 Chinazos, then we can actually just buy the cloning machine. We can actually make a difference. I think that that's really, in addition to decriminalizing, it's like the different areas that we need to address because this doesn't affect one sector.
What do you think? Where does this? How could we make these changes from your perspective? Where could we turn this around?
Right, so I mean, I think it goes back to what Tracie says about the sort of othering, right? And so we have different systems of care. We have the sort of traditional system of care where people go, to their primary care doctor, they go to emergency room, and they go to the hospital. And then we have very segregated from this mental health care and addiction treatment. Why? I mean, why? That makes no sense, right? It's one person who now has to go to 3 different kinds of doctors, 3 different geographical locations. These systems don't talk to each other. In fact, they're prohibited from talking to each other by federal laws. It doesn't make any sense. Right? And this plays out in so many ways in the healthcare system. So, as a physician, I got 1 hour in 4 years of my training on addiction. 1 hour in my 4 years of medical school. And unfortunately, I don't think that's changed that much. Yeah. Right? I mean, we are just now having a subspecialty in addiction medicine that didn't even exist. Just now, just now. Again, why? And I think there's so much stigma associated with addiction. It's about who addiction affects, even though we know it affects everybody. And so that has to change. Right. That absolutely has to change. So we have to bring addiction treatment, mental health treatment into mainstream healthcare. We cannot have 3 different systems. Right? And we have to have training in all of these areas, that has to just be part of the routine, training for physicians, for primary care, in the emergency room, in the hospital. It can't be seen as special or different or unique. And so, from training to funding to, how insurances have carve-outs to federal regulations, it all has to change. Otherwise, I don't know how we're going to get out of this.
And it's interesting you bring that up. I mean, it's been a challenge for us doing this work in different states, because while I understood that the behavioral health system has developed and grown up, and I've worked in this space where it is separate and divorced from mainstream healthcare, what I have come to learn working in different states is that it's actually different everywhere too. It's not only separate, it's also differently structured in every single state in this country. I was joking with the Secretary of Drug and Alcohol Programs in Pennsylvania last week when she said when she gets together with her counterparts across the country, they have to spend an hour just understanding how each other's systems work before they talk about what they could do better.
Absolutely.
And that's remarkable to me, that's how we have addressed substance use from a health perspective, with this sort of messy, fragmented system that is, there's not a standard.
It's baked in. I don't even use the term behavioral health because I feel like it implies that the behavior is the fault, right? And so if we're going to say behavioral health, then we should also include diabetes and lung cancer and all of that, right? Because it's all our behaviors. When I worked in the governor's office, I was assistant secretary for mental hygiene. Even that, it's like mental dirty, right? And in the law, there is a Department of Mental Hygiene. And it was very telling to me that the agencies that were under the mental hygiene department, developmental disabilities, mental health, and addiction, right? So in the law, from the 18th century, we still have constructed a way that we're relegating these issues and these people down here and these people here. And so, again, it kind of bleeds through all of it. Now, many of us in the room, many of our mentors are in the room, we have lived through the arc of our emergency of HIV, right? We've lived through it. There are those of us who didn't think we would be where we are today. And so one of the issues, you talk about stigma, and obviously the intersection with injection drug use and the innovations that we were able to make happen in this like 40-year span. But we're also, we're addressing legacy of Rockefeller. And so remember when we didn't have enough AIDS specialists? We didn't have enough people in infectious disease? Right. What did we do? We increased the rate, and all of a sudden, everyone's in, right? Infectious disease docs or primary care physicians. We need to incentivize treatment, the treatment professionals into this system. Right now, they get paid crap, right? And so the provider networks are skimpy, and we let insurance plans discriminate in terms of what they'll pay for in terms of health and what they'll pay for in terms of, again, mental health and addiction. We have a federal parity act to prevent that, and yet we let the insurance plans continue to do it. So it's going to be money. It's going to be money. It's just about where we're going to apply that money in a way that makes sense. Not at the end, right? And thinking about how do we prevent overdoses, but how do we prevent problematic drug use in the first place?
Exactly.
Absolutely. I mean, I couldn't agree more. It's about, how do we fix this? It really has to do with money. And so we need incentives, right? So we need incentives. We need billing structures that incentivize people for doing this. I mean, right now, the way that this has happened, and I can tell you in our system, it's been doctor by doctor saying, come on, you can do this with me.
It.
I mean, that's crazy. Yeah. Do we do that? Do we do that with heart disease? Do we do that with diabetes? I mean, that's just crazy. No, right? And so how do we incentivize? We incentivize health systems, right? So if your patients get readmitted with heart failure, you're penalized.
Right.
Why heart failure? Why not addiction, right? You get additional payment for HIV. Why not for addiction, right? You have, you can get special loan repayments from, for medical providers for going to certain locations. Again, why not addiction? So we have the tools, and we do this in other areas of healthcare. We just haven't done it around addiction. And I think it's really that we haven't had the leadership, at sort of the federal level to stand up and say, enough, this is where we're going to put our dollars.
Right.
And when we put our dollars in the health systems, they turn on the dime. they turn on the dime,
That's it.
right? Instead, we're really, sort of going around person to person, clinic to clinic, providers. I mean, that is not how we are going to change this epidemic.
Right. And I think also, we have to think about what's happening in communities, right? So, before people go to the doctor, after they leave the doctor, even what happens, what does the neighborhood look like?
Exactly.
What's available to people? And who's out there engaging with people in community? And,
Right.
I think it's this irony also that as we've seen more and more interest in police-assisted diversion programs around the country, that we're putting, and you hear I've had police officers say to me, I didn't go to school to be a social worker.
Right.
I went to school, or I trained and I took this job to be a police officer.
Right.
And while public safety may be connecting somebody to services, it's not something that we train law enforcement for, nor should we be asking them to do it. And why not invest in an army of social workers, actually, and take that off the police entirely? If we're going to talk about changing who and how people are engaged, in the community, I think that's an enormous problem
Or
that
pay,
we're still
pay
sort
people
of
with lived
tension.
experience who can actually make the connection to do
Right.
that work.
Right.
Community health outreach has been fundamental all along, whether
Right.
it's maternal child health,
Right.
HIV, STDs.
Right.
But if we're not valuing that lived experience to be able to make the connection, and if we invest in that, we will see the results.
Right.
I don't think the police should be involved at all in diversion. I think that again, because it's money and where we've invested it and where we have removed it. So if we invested in a community infrastructure that allowed for, people to come into the healthcare system in community, right? As opposed to putting the onus on you, figure out managed care, figure out who your primary care physician is, figure out how to get on the exchange. It's not going to work.
Build community
We
health
have to
workers
build
into
community health care.
system everywhere. Yeah.
Absolutely.
Yeah.
I mean,
So we're not even talking about drugs specifically,
Yeah,
right?
right.
Like
Right.
in that way, we're not talking about drugs
Right.
specifically, but the criminal justice intersection in this issue is what we need to get out of. Why do you have to go through a training to be able to prescribe a medication?
Especially when you can prescribe opioids without any training.
Oh,
Which is
yeah.
why we got here. But we have to have a special training to undo what we've just created.
It's
Yeah.
backwards.
Absolutely. And this is the only special training that we go through to prescribe this medication. So I can prescribe anybody in the room as much morphine as I want, no problems. I can even prescribe chemotherapy to anybody without any special training, but I need special training to get to prescribe buprenorphine for people who have an addiction.
Again.
I mean,
why?
why is that?
Why?
Right.
Right. It's yes.
So what can we do? So we've got a few more minutes. So what can we leave people with? What can people in this room do? What could we demand government do?
Okay, so I'm going to go a little wonky. There's a lot, the risk of overdose for people coming out of correctional facilities is so much higher than it is for the general population. And while we need to do better and recognize the link between community and correctional health, because we did that, right? If there are inequities, it's probably because of incarceration. So really addressing the fact that most people come home from the correctional system and investing in reentry like we do in discharge planning in the healthcare setting. What we're doing a lot of work on at Legal Action Center is trying to get Medicaid dollars, which are the adequate dollars, behind the walls, which they're currently restricted by Medicaid law, to fund that work to enable people to come out and get connected. If the community's sick, they're going to go in sick, they're going to come back out sicker. I'm not saying Medicaid needs to pay for all of correctional health care, but there needs to be oversight. And so some way that acknowledges that health care inside of corrections, which is 18th century, never mind 19th century addiction, that needs to be connected to the community and to community standards. We can do that.
We can. And I think it's a conversation everywhere, but nobody's mastered it yet, it seems. A lot of states are talking about this. It's even more of a challenge in jails.
Yes.
Because people are detained in jails, and so they're released, and nobody knows when they're going to be released, and their Medicaid's turned off.
Right.
And we need them put, yeah.
But for the time that jails have people, they are responsible for their health care. And so if you can get me my medicine for hypertension, you can get me my Suboxone.
And make sure I have something on the way out.
Right.
That's right. Yeah. Yeah. What do you think?
We need resources. So
Yeah.
we need resources, and I think we have a blueprint from history, which is HIV. So it's investing in communities, it's investing in prevention and treatment, it's incentivizing the healthcare systems and holding them accountable for treatment, right? It's requiring education and training at multiple levels. But all of those things really require resources. We have a blueprint. We don't have to make it up.
Yeah.
We know what to do. It's really about the will of leadership.
And some implicit bias training, because that's the other piece in terms of, you know, if healthcare addressed addiction and mental health in the way it could have and should have, one could argue we wouldn't have such a representation in the correctional setting. It's not an accident that so many people who are in prison and jail also have mental health and addiction issues. It's not. So.
Right. And we could deregulate buprenorphine. We could get that so that special training could be done away with, and you could prescribe it as a medication.
Absolutely.
Yeah.
Yep.
And really, it's just full integration into primary care, full integration of mental health treatment and addiction treatment. I mean, even methadone, you know, deconstructing the whole methadone program. I mean, why do we do this? Most of the world does not have these isolated methadone programs like we do in the country. We created it. Why? Right, and so really thinking about these regulations that we've created, and you know, deconstruct them.
Right.
Questioning them.
And then I guess just looking at the show of hands that we saw at the beginning, what can people do if they have a loved one who's struggling with drug use? What can we support one another to do in this until we have the right doctor, until we can not go to jail?
I mean, I would say in terms of opioids, we actually have good treatment.
Yeah.
The treatment is there. The problem so much of the time is that the people who need treatment are not able to access the treatment. And so, you know, we should demand that our medical providers provide treatment. You know, can they refuse to provide treatment for any other condition? Right? So, I mean, I think it is, you know, getting to a medical provider, you know, having these open and honest discussions about what's happening, and really, you know, demanding treatment that's present, that's available, and really pushing the system to make that happen.
I think for individuals who are struggling themselves and for their family members, they need to understand this is not a quick fix issue. And part of the challenge is that if we don't see people, we don't see the benefit of, you know, kind of coming into recovery, coming into treatment, then you don't know the benefit of it. There are a lot of us, present company included, who live wonderful lives in recovery, and it can look, and it is good, but there's no quick fix. It's not a one size fits all either. And recovery is what you want it to be. It's what you want your life to be. So people need to know that there is hope. They need to know that you can have a very full life. And they need to know, though, that when a person is ready, they need to be able to get it's treatment on demand in a very real sense. It's in the moment. So, you know, there's so much that we know how to do, and we just don't employ it. Recovery, lifelong, needs to be supported. It's not like that.
Right. We need a healing environment.
Exactly.
Thank you very much.
Thank you.
So we have time for a couple questions from the audience. Well, wherever you can get with the microphone. Yes, Richard.
Hi, Richard Ilovich. I really applaud Vital Strategies for the work that you've begun to do, and also for the excellent speakers and you, Daliah. I want to sort of build on something and then pose a question. I've worked in post-communist countries, and someone once wrote a book that said, Marxism is dead, but Karl stayed behind. And in a certain sense, we've either opposed the drug war or there's drug war fatigue now. But we still are working with the same frame. We're still working with the same false choices, which is, the incarceration system is you're going to toggle someone from moving from a criminal state to a non-criminal state. The drug treatment is set up that we assume that everyone who shows up with any question, any problem with drugs is an addict. They embody a category. So we're not treating people. We're not asking those basic questions. And in that 1 hour of training, I'm trained on addiction. I'm not trained on drug use. I'm not trained to work. And we've seen so many mistakes, and one sign that NIDA is not a science agency is it does not entertain the mistakes it's made. Whether that's women in crack, whether that's young men of color and marijuana. I mean, in the early 2000s, I was seeing, as the crack epidemic was waning, drug treatment programs filling up with young men as a diversion from incarceration. They had to produce clean urines and basically produce themselves as addicts because the treatment system is still set up as one size fits all, and they're segregated modalities. And we have to, kind of going to your issue about education is we don't, because the government is running the science and it's tied still to what remains of the drug war, we have the false choice of imagining that treatment is meant to toggle people from one state, drug use, to another state, recovery. When I actually think, and I saw this in Central Asia when I ran into an overdose epidemic, is that many people don't know what drugs they're using. We don't understand, the alcohol use, depressant use, and crack use. It's gotten fetishized to fentanyl. But we don't have a basic science. We don't have, and because we don't have a basic science, we also don't have basic, an advanced education in how to work with drug users and different populations. So I'll throw out my question. So my thing is,
Ask your mentor to get to the question.
so my thing is, we actually, I don't think it's about tweaking systems. I actually think we have to back up and say, it's a time for reckoning, time's up. The government can no longer be in charge of doing this. They failed 50 years of the drug war, and here's the question to you, Tracie, is why isn't methadone out there? Why isn't Suboxone out there? Why isn't buprenorphine out there? Think about with designated driver. Designated driver is not an intervention that we do to people. It's something that, it was a social movement that pushed it into existence, but it's something that people organize themselves, and particularly opiate users are constantly organizing themselves. So I think we've got to actually tilt the axis. And it's a much more radical turn, says a 65-year-old. It's a much more radical turn that we've got to do that basically says time's up. And Tracie, you had mentioned something about methadone and its lack of availability, and I think this is an indicator. And I wish you'd talk a little bit more about why isn't methadone widely available?
I'm going to defer that to the doctor.
Yeah, I mean, I think that's an excellent question. And so, we have a completely different system with methadone. We have states that do not have a single methadone program. A state without a methadone program. Could you imagine if in a state we said, oh, we can't treat heart disease, we don't treat cancer? I mean, how is that even, how do we stand with that? How are we not completely outraged? And then there's so many other states that have 1 or 2 methadone programs. And because of the methadone program that we created, people would have to drive 2, 3, 4 hours every single day to get their medication. Right. There is not a single disease that we require this for. Why are we requiring this for addiction? There's no science behind that requirement. We created this system. And I totally agree. We have to undo this. We have to bring healthcare together and include this whole spectrum of health and disease.
Right.
And be able to treat this. It's a chronic illness. Let's treat it like a chronic illness, like all the other chronic illnesses that we have, like diabetes, like heart disease, right? And let's not make it separate and different. And I think the methadone is a great example of, if we're really serious about changing this epidemic, we have to change the way that we deliver care.
Right.
Fundamentally.
Judges shouldn't be able to say when you're on or off methadone. That's one of those things. We work on those issues. We have, in this country, judges who are demanding that people get off of methadone or Suboxone or lose custody of their kids or stay in jail. This abstinence base really goes to, I don't know, maybe it's our Puritan beginnings. I have no idea. But this false notion that you've got to be clean, you got to be abstinent, means that it cannot tolerate anything that mitigates. We're going to look back on this time as completely barbaric, and harm reduction will be the norm. Mm-hmm. But right now, we're in the mix.
Okay, I think we have time for one more question, maybe 2 more if we keep it brief.
You just said something. You said mentioned the Puritans. When the Puritans arrived, one of the first things they did was they built cemeteries, jails, and public scaffolds for shaming, for public shaming. Mm-hmm. So they were already prepared to treat addiction, and not much has changed since their arrival.
Thank you.
You mentioned, we keep talking about buprenorphine and methadone. They've been around for a long time. We got to come up with something. With best luck, those drugs are going to maybe help cure half the population that's got an issue. So we need more research. We've got to come up with something newer than drugs that we've been using for 50 years without a whole bunch of success.
Right, and can't talk about opioids only. People are polydrug users. And the FDA-approved meds for the opioid use disorder is great, but if somebody's using other things, and I mean, benzodiazepines and cocaine and crystal meth and the contamination with fentanyl, but we want one size fits all. We want an easy fix. So just.
I would also correct to say we've been talking about use the term opioid epidemic a lot today. We're in a drug crisis.
Yes.
It's a drug epidemic.
Yes.
In the western part of this country, methamphetamine is already sweeping the country. Yes. My question is, you say we've got a blueprint from the AIDS epidemic. The one thing from the AIDS epidemic that we have not copied is we are not in the streets. Yeah. We are not demonstrating. We are not getting out there. It's hard to get dead people to protest. Yeah. So it falls to the survivors. And my question is, what do you suggest we do about that?
I mean, we have to be outraged. It is outrageous that only 10 to 20% of people who need treatment get treatment. How are we okay with that? I mean, we would never be okay with that with anything else. I mean, I totally agree. I think, what I think from the HIV epidemic is that so much changed really because of gay white men who had power, right? Not because of the injection drug users really, didn't have the power. And so now, I think we have to have that outrage to really push our government to change. We are nibbling around the edges. We are not going to change this epidemic unless we make some really fundamental changes here. And talking about medications, I mean, HIV has a whole earmark for HIV-related research that is more rapid than any other research in this country. We can do the same thing around drug use. We can do the same thing. Again, we need the will. We need to be outraged. We need to push our leaders here to make real changes.
Families need to weigh in, and I will tell you that when I was in government and people wanted to talk about opioids, I did not have one family of color, one family member of color. It was all white moms from Staten Island and Long Island. So that idea, like there's even, people don't believe, like black and brown people are in recovery. Black and brown people have healed, but the stigma is such. The stigma is so deep. So being in the streets means that you can afford what that means, to be in the streets, to be seen, and the invisibility of this. But there's definitely the energy to organize will have to start with those who are considered to matter.
I can't take any. Can I take one more? One more? Can we have one more question? No. Yeah? Okay. Maybe I'll come to this side. Yeah.
To follow up on the
Very
solutions-based approach, my name is Victor Velasquez. I'm from Exponents.
You
Two
have to.
things you raised that were very important. One is incentivization, and two is education. And we've married those two in two wonderful free programs that we offer at our agency, so we can be the tip of the spear when it comes to education, and hopefully bringing people to the treatment and bringing them to understand what it means to be an addict and still have a normalized life.
Exactly, but you all also organize people. So treatment and health is political. That's what makes you different.
Thank you so much. And I have flyers, you can see me after.
Okay.
To the free service.
Thank you. Thank you. I think that's it. We're done. I'm getting the signal. So thank you, everyone, and thank you to our wonderful guests for a great discussion.